Assalamu alaikum. Bismillahirrahmanirrahim. My name is Dr. Yasir Abbas Zaidi, and I'm working as an assistant professor of gastroenterology at Nishtar Medical University, Multan. On behalf of Pakistan Society for the Study of Liver Diseases, I would like to welcome you all on the Symposium 8 of the 14th annual conference being held online in the wake of this pandemic. So this my session that I'm going to moderate, it is going to be with on chronic hepatitis C. And it is going to be of importance for both our graduates, undergraduates, postgraduates, and general practitioners, and all the gastroenterologists around, as we are going to refresh our knowledge on one of the most hottest and the most commonly used problems that we encounter in our day-to-day practice, both in our institutes and in our clinics. So this symposium number 8 on chronic hepatitis C, we have a galaxy of stars that I would like to call of our subject of gastroenterology. This session is going to be chaired by Professor Wasim Jafri, Professor Sadiq Maiman, Professor Adil Bhatt, Professor Sharbat Khan, and Professor Qazi Masroor. And I'm going to be the moderator for this session. Some certain house rules will be like we have to stick to our timeline. So we'll be having our lectures, and we are going to take all your questions in the chat box. And at the end, we are going to have a little interactive discussion regarding your questions. And then, as we have been doing, we have our little questions that we are going to we would like you to answer, and then you can win cash prizes. So with the approval of our moderators, I would like to invite on stage first Professor Saeed Hamid, and he will be shedding light on the topic of treating co-infections, hepatitis B, C co-infections with or without hepatitis D, hepatitis C co-infection with hepatitis with HIV. Professor Saeed Hamid is a well-known name in the subject of gastroenterology. He is the professor of Department of Medicine and director of the Clinical Trial Unit at Aga Khan University, Karachi. He formerly served as chair Department of Medicine from 2008 to 2018. He trained in medicine and gastroenterology in the UK and in hepatology at the University of Texas Southwestern Medical School. He has been the vice president, Pakistan Society for the Pakistan Society of Gastroenterology, and president of the Pakistan Society for the Study of Liver Diseases. He has also been a member of the guidelines and the publication committee of the WCO, member of the executive council of the Asian Pacific Association for the Study of Liver, and has chaired WHO guideline development group for hepatitis in 2015 and 2017. He is currently the member governing council of the World Gastroenterology Organization, co-chair of Coalition to Eradicate Viral Hepatitis from Asia Pacific, and member of Oversight Committee, NHEP 2030. His main research interests are viral hepatitis and liver failure. He has been an author on over 150 peer-reviewed publications. He has mentored a number of postgraduate GI trainees, PhD, and other graduate students. With this, I would like to welcome you on the stage, sir.
Thank you, Yasir. Do I need to talk, or shall we just conclude at that?
So we would love to hear whatever you have to say.
Okay, can I have my slides, please? All right, so I'm sorry we are a little bit out of sequence here because Dr. Reddy will be coming a little bit later. Anyway, let me talk about managing patients with hepatitis C and B co-infections and Hcv and HIV co-infection. In the title there was also hepatitis delta, but I don't think I will have time to cover all of these. Now, if I can move my slides, I think I can. Okay, I have no disclosures. And all these three viruses are blood-borne viruses, everybody knows. Of course, hepatitis B has the largest footprint, more than 240 million people, and then HIV, then HCV, and then HIV. But there are, as we all know, important differences because whereas HIV and Hbv are viruses that persist in the cell, Hcv does not, because it does not enter into the nucleus, of course. And therefore, we need to keep this in mind when we talk about the co-infections and treatments for these infections. Some general statements about hepatitis B and C co-infection. The prevalence of Hbv-Hcv co-infection is estimated around 1.4% in the US and 5 to 10% globally, meaning that there are many countries in the world or many regions in the world where hepatitis B is quite prevalent, as is hepatitis C, and therefore these two viruses often combine. Persons with Hbv and Hcv co-infection and detectable viremia, and the term used here is detectable viremia, so both are active infections. If such is the case, that puts the patient at increased risk for disease progression, for decompensated liver disease, and the development of liver cancer. So therefore, these infections are important in that sense, although they may not be the majority of patients that we see. Hbv and Hcv co-infected individuals are susceptible to a process called viral interference, wherein one virus may interfere with the replication of the other. And as we know already, it is usually the hepatitis B virus that interferes, the hepatitis C virus that interferes in the replication of HBV, driving the HBV DNA levels downwards. What is the pathogenesis? So HBV DNA is often low or undetectable in these individuals, and by and large HCV is responsible for the activity of chronic hepatitis in most of these patients. There is a potential risk, however, of Hbv reactivation during treatment, and we'll talk about how important or unimportant this is in our daily practice during treatment or even after clearance of the hepatitis C virus. Therefore, some people suggest that HBV DNA monitoring is necessary during treatment and after treatment, and we will discuss. These are some points of contention that we need to have a debate about, because we see a large number of hepatitis C patients and we treat them right, left and center, and we are developing large programs for elimination. And how does that gel in with the HBV co-infection? So the recommendation is that any Hbv reactivation, of course, must then be treated with the nucleoside analog. So there's a whole different perspective to the HCV elimination or treatment effort. What is the situation in Pakistan? We don't have very good data, but whatever we have, this is the hepatitis general population survey done in 2007-2008 by PMRC. The prevalence of B surface antigen positive people in this survey was 2.5%, which makes it approximately 4.25 million people infected. Of these, only 1% were found to be HBV-HCV co-infected, and that comes to 42,500 out of the 4.25 million. And that is really not a very large number when you think about the whole population of B positive patients. This is our own data from the Malir district, where we run a number of microelimination, HCV microelimination programs. We've tested something like 14,000 plus people in these efforts. The HCV antibody positivity was about roughly 2,000 out of these 15,000 people, so well above 12 or 13%. And all of these, according to our algorithm, all of these are tested for hepatitis B surface antigen. We found only 29 out of those roughly 2,000 people who was surface antigen positive, giving a prevalence of about 1.5%, which is something similar to what was suggested by the national survey. Moreover, we have not observed any treatment flares in any of the HCV patients that we've treated in these campaigns with DAAs. Of course, we do not immediately embark on HBV testing and further testing of HBV and treatment. Once the treatment is finished, we do link them to treatment for hepatitis B in places where this can be done. So the thing to say is that while this is important clinically, it is not really a tremendous group of people that we see in our overall clinical practice. So if you're faced with a person who is HBV or HCV co-infected, what are your assessments? So of course you confirm the HCV with an HCV RNA. The surface antigen has come out to be positive. Now you do a further testing with E antigen and anti-HBe, and some guidelines even recommend doing an HBV DNA in everybody who's surface antigen positive in this scenario. That is certainly not practical for us in our even in our daily clinics, but particularly in our programs, in our community programs, that is not generally possible. You do a fibrosis assessment because that to some extent determines whether you investigate further there and then for hepatitis B, and whether you start treatment or not. So in general, you're assessing these people for therapy for hepatitis B. And as I said, many of these recommendations will say that treatment is recommended for all patients with chronic HCV. Sorry, this is for chronic HCV, but people will say that some sort of treatment is also recommended for B, and we'll come to that in the next few slides. So the main issue is reactivation of hepatitis B treatment, of hepatitis B infection with treatment of hepatitis C. And there have been reported cases, particularly when we were using interferon, but also multiple cases since we have been using the DAAs, especially the initial DAAs, subosvir, simipvir combinations, anisopvir, declatisvir combinations, and so on, but also with lead and SOF, which is used quite frequently in HIV infections and HCV co-infections, for example. Certainly, this is okay, no problem. Right. So other reports suggest that the risk is low for hepatitis B reactivation in patients who are just anti-HBC core positive, meaning that they've had an exposure, but they do not have active, or they supposedly do not have active HBV infection. And these are studies from Taiwan and Korea. 60% of these patients had anti-HBC positivity. Serum samples were analyzed for HBV DNA by PCR during treatments with for DAAs, for hepatitis C with DAAs. None of these patients showed evidence for HBV reactivation during hepatitis C therapy. So there is some comfort to say that people who are just anti-HBC positive, the risk of reactivation is very, very small, if non-existent maybe. However, these are the two guidelines that I need to quote and we may need to discuss. Surface antigen positive patients, this is the ASSLD now, surface antigen positive patients are at risk of HBV DNA and ALT flares with HCV DAA therapy. And monitoring of HBV DNA levels every 4 to 8 weeks during treatment and for 3 months post-treatment is indicated. How relevant and how practicable that is for our setup is something that we need to figure out and discuss and decide. The lower guideline is, or the sentence is from the Ssld guideline, surface antigen positive patients undergoing DAA therapy should be considered for concomitant nucleoside analog prophylaxis until week 12 post DAA. So in other words, they are recommending anybody who turns out to be surface antigen positive will need to go on to DAA therapy prophylactically and for 12 weeks during the duration of DAA therapy and 12 weeks after the end of therapy. That is 24 weeks of a nucleoside analog treatment. There is certainly, I should have put this slide a little earlier, but there is certainly a risk of HCC becomes higher if patients are positive for both HBV and HCC. However, this study from Taiwan suggests that this risk probably remains the same and is related more to hepatitis B than to hepatitis C. As you can see in the second line, patients who are surface antigen positive alone, the odds ratios are 32. And in the last line, if you see, if there's both positivity, even then the odd ratios remain about 32, so they haven't changed that much. These are 3 cases that have been reported with the newer oral DAAs, and the first column on the left that you see is surface antigen positivity. 10 patients, out of which 3 had a flare. 1 had developed hepatic failure, and there were no deaths, I believe, in this. People recovered. And then the other 2 columns are of occult hepatitis B infection, where there were no incidence of icteric hepatitis at all. So if anything, very, very mild or none whatsoever. So what to do to conclude this part? What to do in Hbv-Hcv infected individuals? Obviously, test all Hcv positive, antibody positive patients for hepatitis B. This may not be immediately important, but it becomes important once you've treated, so that you don't leave the patient alone, and you investigate for hepatitis B and for candidacy for treatment for hepatitis B. Treat for hepatitis B in addition to hepatitis C if treatment guidelines are met. For example, if you do a DNA and that is above 20,000 for any antigen positive patient, those are treatment guidelines fulfilling criteria, and they may need to be treated, and one can treat them together at the same time. If advanced fibrosis is present and or patient would not tolerate reactivation of hepatitis B for any reason, then treatment is needed regardless of the hepatitis B virus status. Hepatitis B surface antigen negative, anti-HBC positive, in other words, previously exposed people but not active infection, do not need treatment immediately but should be followed up. With what frequency, that we can discuss. Here it is suggested every 4 weeks during HCV therapy and even thereafter. But that is again quite a tall commitment in large HCV programs. So we'll come back to that in the discussion. Now going to the other part of my talk, which is the HIV-HCV. So this is international data, but this data is very similar to what we have. That means that 90% or maybe even higher, 95% of our HIV population, which is intravenous drug users, are also HCV infected. So that's a huge, tremendous percentage, and that is due to basically sharing of needles and other high-risk behaviors. And therefore, this is quite a large group. The HIV is not a small proportion in our country, and mostly it is injection drug use driven. So this will become an important group clinically as we move along. In fact, it already has. The important thing to remember is that with improvements, significant improvements in therapies, and also the continuous therapies for HIV, liver disease has become an important cause of mortality in these patients rather than HIV. So I think that needs to be remembered. And the impact of viral hepatitis can vary. If you have, for example, a hepatitis B, Hcv, HIV co-infection, then the impact on mortality is nearly 40%, 45%. If it's C alone, it's less. If it's B alone, it's less. If there's no Hcv, Hbv, it is minuscule. So hepatitis B and C co-infections do determine what would be the source of mortality in these patients. Remember that 50% of patients who died in these studies of end-stage liver disease had well-controlled HIV infection. So CD counts are more than 200 in most of these patients. These are just basically data to tell you the disease progression in monoinfection as compared to HCV, HIV co-infections, and there are 3 lines. The blue line is HCV monoinfection, the red line in the middle is co-infection but with effective HIV therapy, so HIV RNA levels less than 1000, and the green line at the top is HIV co-infections without effective HIV therapy. And needless to say, the ones without effective HIV therapy do the worst in terms of disease progression and years to hepatic decompensation. The same holds true so even if CD4 counts are maintained, these patients continue to deteriorate much more than if there is just HCV mono infection. So the combination of these two, despite well-controlled HIV, is playing an important role in mortality. This just gives you in a diagrammatic fashion the odds ratios. So odds ratios of 2.07 for histological cirrhosis, for the presence of histological cirrhosis, and 6, nearly 6 for decompensated disease. Why is the liver more progressive in those with low liver disease is more progressive in those with low CD4 counts? We've just talked about the intestinal microbiota. So there is microbial translocation with lower CD4 levels, and this aggravates the HCV steatosis that was already present in the liver, and that leads to cirrhosis. Well, that is at least what the theory is. This is a meta-analysis of the prevalence of hepatic steatosis in HIV, HCV co-infected versus HCV mono-infected patients. And you look at the last line, which is the pooled data. It is 1.6 odds ratios, so therefore important parameter which will determine what the frequency of liver disease would be. Interestingly, there has been no decline. In fact, maybe it has gone up. The prevalence of end-stage liver disease as the ART therapy, the anti-HIV therapy has improved. So the yellow bubble is the modern ART. So if you look at HBV positive plus HCV positive co-infected, triply infected patients, even the modern ART has not made any difference. In fact, the end-stage liver disease has gone up, which means that it is critically important to treat these co-infections in these patients if we are to make a dent in their mortality. The good news is that there is really no difference in treating, no difference in the therapy, and no difference in the outcome in treating HCV infection, whether this is a mono-infection with HCV or HIV co-infection. The results are almost exactly the same in a number of combinations of pan-genotypic combinations, as you can see on this one slide. So that makes life quite easy, except for one or two caveats which we will come to in a little bit. These are the Ssld recommendations for first-line HCV treatment in HCV HIV co-infection. I would just like you to concentrate on the second row, which is the genotype 3 one, where we basically sit. So GP and SOFWEL are indicated both for cirrhosis and for compensated cirrhosis, except that you go up to 12 weeks if there is compensated cirrhosis, and 8 weeks if there is no cirrhosis. What I wanted why I wanted to bring this article out was because of the fact that you know that our major combination is SOF and DECLA, and we hardly use the other combinations. Certainly we don't have even GP in our armamentarium. So what does SOF and DECLA do to the co-infection status? This is one study that I found. Unfortunately, genotype 3 is not very well represented. Only 6 patients in the naive group and 4 patients in the experienced group, but still a large study, mostly of genotype 1 and 1A and 1B. And the important thing was that if you look at the overall results seem to be pretty promising. And look at the right-hand column, all patients, leave out the genotype 1 on the left-hand side, and you can see that 97-98% responses. The 8-week therapy which they tried in this study was no good. It was only 76%. So the bottom line message is the soft DAC does work in HIV, HCV co-infection, and I think we can use that reasonably safely and with some assurance. So this is just a revision. Consider potential for Hbv reactivation, of course, that we've talked about already. Test all patients initiating HCV DAA therapy for hepatitis B, and do consider putting this in. Most of these patients would anyway be on one or the other compound, which is not just effective for HIV but also for hepatitis B. So So less of a risk when compared to HIV non-infected patients. The main caveat is that we need to remember the drug-drug interactions, and these are extremely important. We don't perhaps pay that much attention to these charts when we are treating HCV mono infection, but we can see there are a number of crosses on this graph and on this chart. And what are these crosses? So co-administration of HCV and HIV protease inhibitors not currently recommended. So many of these combinations will go out which contain even the newer protease inhibitors. Co-administration of lead and ledisvavir and or valtazapir with TDF but not TAF requires liver monitoring. So that's a caution, not a contraindication, but certainly a caution. So this is something that we need to remember, and it is perhaps best if you're treating many patients just to carry this as a cheat sheet in your pocket. The difficulty is that there is a huge incidence of reinfection after SVR in these patients with co-infections. So if you look at the right-hand column, this is the HIV HCV population, and the risk for recurrence goes up to something like 25%, whereas just in the high-risk IDUs, which are non-HIV, the risk is about half that, and there's certainly very low risk in the low-risk population. So that is something that one will be confronted quite frequently when you treat such patients in your practices. So to summarize, treatment of HCV and HIV co-infection in patients, all persons with HIV should be treated with potent ARTs, especially those with hepatitis C. Despite ARTs, however, HIV infection is independently associated with HCV disease progression, as we've seen the data. HCV treatment should also be a priority for persons with HCV-HIV co-infection. Efficacy and adverse events for HCV DAAs among those with HCV-HIV co-infection are similar to those observed with HCV alone. Co-treatment requires continued awareness and attention to the complex drug-drug interactions that can occur between DAAs and the antiretroviral medications for HIV. With that, I will stop and pass this on to the moderators. Thank you very much.
Thank you very much, Professor Saeed. It's always a pleasure for the eyes and the mind to see you talking and listening to how you manage to make these difficult topics so clear and crisp. And believe you me, whenever I see a hepatitis B patient, I just always look up to whatever you've seen you've taught us in the past years and all, and it always looks to me like a guiding light. So I believe we are back on track again, and we can take up from. And yes, I would like to thank you for saving us, because you had to fill in. You were on the second on the list, and you took up the first talk. So I believe if we have Dr. Rajendar Reddy online, so if we can confirm that.
Yeah, I'm online. Can you hear me?
Yes, Dr. Rajendar, if you're there. So Dr. Rajendar was our first presenter for today's session, and his title was "Difficult to Treat Patients in the Era of DAAs." Dr. Rajendar is a very well-known figure in our fraternity, and he's the professor of medicine and surgery in the Division of Gastroenterology at the University of Pennsylvania in Philadelphia. He's the director of hepatology and medical director liver transplantation at the University of Pennsylvania School of Medicine. Dr. Reddy has numerous publications and is a renowned author in various medical journals. He has been recognized among America's top doctors from 2007 all the way up till now. So I would request Dr. Reddy to please to take the mic.
All right. Can you all hear me?
Loud and clear, sir.
And also see my slides as well, right? So
yes.
Thanks so much. Well, first of all, thanks very much for having me speak at your annual meeting. It's really a pleasure, and it's nice to see so many familiar faces. So hepatitis C has been around for some time, but I think it really have come a long way. If you were to look at the history of hepatitis, well, non-A, non-B, and hepatitis C. And I've been in this field for about 30 odd years, starting from the days of interferon given for 6 months. We've come a long way, and it's really great to see people being recognized this year for their work in hepatitis C. Well, they began with non-A, non-B hepatitis, of course, Harvey Alter, Mike Houghton, and Charlie Rice. So we've really come a full circle, and we've made a lot of advances. So from the days of interferon, we've now reached to a state where we've really developed great treatments for hepatitis C. Overall, we have a greater than 90% sustained virologic response. I know in Pakistan, some of these combinations are not available. Maybe they are now at, for instance, sofosbuvir, velpatasvir, and voxilatravir. Combination, which is the ultimate for non-responders to DAAs in terms of therapy, is not available, or at least was not available when I last spoke with colleagues there. So we really have a great armamentarium of drugs to treat hepatitis C with great success and great tolerability. So just to give you a bit of an overview, glucapavir, pabrentasvir is a great combination for all genotypes. Again, this is a combination that's not available in Pakistan, was not at least six months ago when I spoke to some folks. It works well in patients with and without cirrhosis, but compensated cirrhosis is the group that needs to be treated, and not decompensated cirrhosis because of a protease inhibitor, and 8 weeks therapy is great. And then we have sofosbuvir, velpatasvir, which also works extremely well even in genotype 3 patients. And this is available in Pakistan, I believe. So then, apart from great treatments, we have generic drugs, inexpensive drugs. You have soft velpatasvir, soft decladisvir, readily available around the world at affordable prices. So if you were to summarize, it would appear that 8 weeks is the shortest we can go. Shorter regimens have failed. Shorter than 8 weeks have failed universally. And most of the patients fall into the category of the low-hanging fruit, and they're easy to treat, and we're able to achieve sustained virologic response. Well, then, what I've presented thus far would make us think that everything looks great, right? It's all hunky-dory. So are there any remaining problems? Well, there are indeed remaining problems. And most importantly, it is about screening the population to identify those with hepatitis C and treating them. And then particularly if you really don't have features that identify those at risk, then you need to kind of screen overall population and treat them. So if you were to look at WHO elimination targets, this is a sobering part. At one end, we have great treatments, well-tolerated treatments, generic drugs, yet globally, most countries, or majority of countries, are not on target to meet WHO thresholds by 2030, where they had suggested that 90% would be diagnosed, 80% treated, that there would be a 65% reduction in mortality, and that there'd be a 90% reduction in Hcv incidence. So if you were to look at these various parameters, we are far from getting there by 2030, and we still have a lot of work to do. And what has happened, there are quite a few publications on it based on modeling that COVID-19 has had an adverse impact on the path to meeting these thresholds. So everything's been delayed. Hepatitis C in some parts of the world has been relegated by default to a second tier, and it's not on the radar screen as much as it should be, and COVID-19 certainly has played a role in it. So we need to recalibrate the timelines, and there's already talk about it in terms of when we might be able to reach or achieve these targets. Now, in terms of burden of hepatitis B and C in Pakistan, it's an enormous burden. This is an earlier publication, almost a decade ago, at which time seroprevalence of hepatitis B was estimated to be about 2.5%, and seroprevalence of hepatitis C to be around 5%, and roughly it was estimated that there were over 1.3 million infected persons with hepatitis B and C in Pakistan. Maybe the numbers have changed based on more recent estimates. What we have recognized for quite some time is that genotype 3 dominates amongst all genotypes in Pakistan, and you can see here a nice publication that looked at genotype prevalence in various provinces in Pakistan. With the red colored bar or component of the bars represents genotype 3 infection. So what are the remaining challenges? Apart from identifying and treating more and more individuals with hepatitis C infection, there remains a sizable population of persons who inject drugs, the non-compliant patients, those with psychiatric disorders, amongst other marginalized and challenging populations. And these populations also include those who are incarcerated. There are some challenges with the decompensated cirrhosis, given that a protease inhibitor cannot be used in these patients for risk of toxicity. And then there are a few remaining treatment failures, even with the more potent 3 DAA regimen of sofosbuvir, belpatisvir, and voxilatravir. And what do we do with those patients? So if you were to look at injection drug use, this publication points out that this is a mode that perpetuates hepatitis C infection, that is the injection drug use. Globally, there are about 6.1 million people with recent injection drug use, and about 39% of them are hepatitis C viremic. That's an estimate. And you see Pakistan as a small dot there, and the size of the circle relates proportion of people living with Hcv infection among all people with recent drug use. Russia, United States, Chile, Brazil dominate, but Pakistan is amongst the countries where IV drug use contributes to the overall population of hepatitis C infection. Now, there are studies that have emerged on efficacy of hepatitis C therapy in persons with persons who used drugs. This is with gicaprovir and pibrentasvir. Looked at patients with recent use of drugs, former drug users, and non-drug users. And overall, sustained response rates quite good, although somewhat compromised in the population with recent drug use. And of course, in this population, those who were adherent, there was a good response. You have this is a presentation at the recent Ssld meeting, looking at sofosbuvir, belpatisvir, in a strategy of test and treat approach. They looked at adherence, which was greater than or equal 90%, of whom 97.7% achieved sustained virologic response. This is an active PWID population from 7 countries. You see great response rates. Genotype 3 had a 96% response rate. Those who are homeless, incarcerated, those who had mental health disorders had great response. Even genotype 3 and advanced fibrosis patients had great responses. So this is real-world data in challenging populations. Now, another presentation looked at outcomes in those who are lost to follow-up following HCV treatment, and these were individuals who came in later on and did not come in at the 12-week post-treatment time point to assess for sustained virologic response. And what they showed is that on-time assessment or delayed assessment had similar sustained virologic response rates. Now, this is another study that was presented at Ssld, a phase 4 study, looked at a strategy of minimal monitoring called the MinMon study. There are 400 patients selected across 38 AIDS clinical trial group sites. Countries included US, Brazil, Thailand, Uganda, and South Africa. And basically, they were given the drug at entry, and there were only remote contacts. There were no on-treatment visits, labs. And in essence, the bottom line is the sustained response rate was great. I'm sure some of this is being pursued in Pakistan, but it really lends confidence to the strategy that we don't need to monitor them frequently like we traditionally did as part of clinical trials or subsequently, and minimal follow-up is as good as intense follow-up, and then they have great response rates. This is a study in patients with psychiatric disorders, an integrated analysis that was presented with sofosbuvir and valparasvir. High cure rates generally, although patients who had a lower adherence, let's say less than 80% intent to treat analysis, SVR rate was 83%, modified intent to treat analysis, SVR rate was above 90%. So generally, across the board, they responded well, whether they're on an antipsychotic drug or not. Only thing that compromised SVR was adherence. I know genotype, as we pointed out, is more prevalent in Pakistan, so I want to present this real-life data with sofosbuvir and valparasvir in genotype 3 patients with compensated cirrhosis. And this was soft well with or without ribavirin. The orange bars represent ribavirin cohort. The blue bars represent just soft and well. And overall, you can see, again, to emphasize the point, these were patients with cirrhosis. And you can see overall high response rates, a little bit of compromise. And I say compromise, that is below 90%. Was seen in those who were about equal to age of 65. That's with ribavirin. And this makes sense because ribavirin is not tolerated well by the elderly, and this may have compromised the response rates. And the other area where soft and well without ribavirin did not work well was in those who had low albumin. Again, when I say it did not work well, I'm using the threshold of 90%. And they had 88.9% when the albumin was low. Now, What about soft well and walks? Even if you don't have this available, it's important to kind of look at it in real life. This is a VA study looking at soft well walks. And in prior DA failures, majority of them had failed soft lead-pesvir with or without ribavirin. They had 43% of 51 genotype 3 patients that failed soft lead-pesvir with or without ribavirin. And here you can see the response rates. The response rates, if you were to look at those that failed soft well, and I'm just going to focus here, and particularly look at genotype 3, when they were treated with soft well walks, they had an 85% sustained virologic response. But I want to emphasize something. There are only 13 patients in this genotype 3 cohort. 11 of 13 had achieved sustained virologic response. Again, to emphasize, these are soft well failures who were treated with soft well and voxeloprevir. Decompensated cirrhosis. I want to make a couple of points about decompensated cirrhosis, and this, what I'm going to present might be a bit of a sobering experience. I recognize in Pakistan a fair number of patients present with decompensated cirrhosis. You need to know as to what the expectations should be by the physician, treating physician, and the patient. So first point is when you treat patients with decompensated cirrhosis, and this is data that we put together from various DAA trials and looked at 6-month outcomes. If you were to look at improvement in hepatic function as determined by MELD, 60% improved after DAA therapy in the first 6 months, 17% unchanged, and in 23%, actually the MELD score worsened despite achieving sustained virologic response. And as what is also important to recognize is that those who improve their MELD don't improve by many points. More often it's by 1, 2, or 3 points. Very few achieve a MELD improvement of greater than or equal 6. And similarly, worsening also is by few MELD points. And then we looked at a huge database, a real-life database, where we had we had 213 weeks of follow-up, and there were 642 patients with decompensated cirrhosis were treated with DAAs. 90% achieved SVR. And then we had about 158 patients or long-term follow-up, looked at endpoints of total bilirubin, albumin, and MELD score. So if you look at short-term follow-up, 24%, that is a quarter of patients, achieved a clinically significant decrease in MELD by greater or equal 3 points. You might ask, why did you pick 3 points? So if you were to draw blood in a patient at a given time and send it to various labs, you might see a fluctuation in MELD by 3 points. So that should just be laboratory variation. So clinically meaningful MELD may be something that should be measured as above 3 points. Now, in the long-term follow-up, a final MELD score of less than 10 was achieved by 25%. So clearly, there's only marginal improvement. If you look at mean changes in bilirubin, albumin, they're really marginal improvements or long-term. So this is a sobering part. And then 51 patients died and 2,200 went to liver transplant despite achieving SVR. So the expectations have to be tempered a bit. This is a little different than hepatitis B, where you see dramatic improvements. So this is something that you need to talk to your patients. Lastly, I'll end up with some data on those who fail soft well and soft well walks. AASLD guidelines for soft well VOX treatment failures is to use GP plus sofosbuvir and weight-based ribavirin for 16 weeks, or use again SOF, well, and VOX plus weight-based ribavirin for 24 weeks. So these are SOF, well, VOX failures. And if you look at EASL recommendations, pretty much similar. They suggest SOF, glecaprevir, and pembrolizumab for prior DAA failures, and particularly if they fail SOFSVEL and voxeloprevir, they recommend sofosbuvir, glecaprevir, and pembrolizumab for 24 weeks with weight-based ribavirin. There are few of those. The data is limited on SOFSVEL VOX failures, and if you do see failures to previous DAs, it's usually in the context of compensated cirrhosis. We really do not have SOFSVEL VOX treatment in decompensated cirrhosis because voxeloprevir protease inhibitor is not to be used in decompensated liver disease. This is data with GP and SOF plus ribavirin, just 6 genotype 3 patients, 6 of 6 after 12 weeks achieved failure. These were achieved sustained response. These are GP failures. And then if you were to look at SOFSVEL, now I know you use a lot of SOFSVEL. It's been used in SOFSVEL plus ribavirin for 24 weeks in DA failures. And in this study, there were actually 40% of patients who failed SOFSVEL and voxeloprevir. And you look at genotype 3, again, only 4 patients without RAS, 4 of 4 achieved SVR. Those who had baseline RASs, there was 77% SVR. Small numbers, not a whole big experience. So if there's going to be experience, it's going to be from Pakistan with large numbers. So to summarize, we've come a full circle in HCV. I think it's the end of the road for drug development, and it's phenomenal that the work that's been done in hepatitis has been recognized by 3 remarkable individuals being awarded the Nobel Prize. WHO targets will need to be recalibrated. We are not close to be on track. The challenges, as I pointed out, are in identifying patients. Marginalized patients can be treated effectively. I've shown you quite a bit of data. Most of the low-hanging fruit, uncomplicated cases can be effectively treated. But there are complicated patients, particularly decompensated liver disease patients, who may present challenge. There appears to be some forgiveness for missing doses. I showed you that adherence compromised response rates, but not dramatically. And then we have SOFSVEL VOX and GP plus SOF plus or minus ribavirin as the ultimate regimens for DA failures. With that, I'll stop and be prepared for any questions, perhaps during the Q&A period. Thanks very much for your attention.
Thank you very much, Dr. Reddy, for summarizing a very, very difficult topic into a very simple to understand thing for us. We would like you, if you could stay with us for a while, because the question answer session will be at the end. If anybody has a question, we'll put it at the end of the presentation. The next topic for today is to treat or not to treat HCV in patients with hepatocellular carcinoma or patients receiving chemotherapy for other cancers. This topic will be covered by Dr. Tabasak Tanwandee from Thailand. He's a hepatologist, Division of Gastroenterology and Hepatology at Siraj Hospital, Mahidol University, Bangkok, Thailand. Where he has been working for the past 25 years. His current position is Associate Professor of Medicine and Head of Division of Gastroenterology. He also serves as the President of Thai Association for Study of Liver Diseases. He also spent 2 years performing research in virology at the Department of Molecular Virology, Baylor College of Medicine, Houston, Texas. He is the current member of AGA, ACG, Ssld, Ssld, and APASL. So I would like to welcome Dr. Tabasak on screen. Dr. Tabasak, are you there?
I'm here. Good afternoon. First of all, I would like to thank the organizing committee for the invitation, and I was asked to cover on the treatment of Hep C in the patient with active cancer. The topic I'm going to cover is to treat Hep C in a patient with active hepatocellular carcinoma and in a patient with lymphoma and other active malignancy. For Hep C in a patient with active hepatocellular carcinoma, we all know that Hep C accounts for about a third of the patient with hepatocellular carcinoma, especially in some countries where Hep C is majority cause of hepatocellular carcinoma. Now, the treatment of Hep C together with hepatocellular carcinoma, the early study was disappointed by having lower SVR as compared with the patient without hepatocellular carcinoma. As you can see in this landmark study, to compare the two populations, you can see that the patient with hepatocellular carcinoma got up to 21% failure rate as compared with 12% in the patient with hepatocellular carcinoma without hepatocellular carcinoma. However, newer study did not find this difference. And when we look at recent meta-analysis on the treatment of Hep C in hepatocellular carcinoma, including almost 40,000 patients, SVR rate in a patient with active malignancy just about 90% as compared with 93% in the patient without malignancy. So it's just a bit lower in the patient with active hepatocellular carcinoma. There are some proposed mechanisms regarding low SVR in the patient with hepatocellular carcinoma that include suboptimal drug penetration in hepatocellular carcinoma cell and alterations of the inflammatory state in the tumor microenvironment, as well as development of down regulations of the membrane transporter that uptake the DAA, and hepatocellular carcinoma cell itself may act as a reservoir for hepatitis C. The second important thing for the treatment with active hepatocellular carcinoma is including recurrent after curative treatment. However, even the early study has shown some more recurrent in this group of the patient. With recent systematic review, including 41 study, there was no difference in recurrent as compared with the patient without treatment. And large multi-center US and Canada involved almost 800 HCC patients. Overall, an early recurrent of hepatocellular carcinoma did not different between treated and untreated. And the treatment with SVR will result in lower mortality as the improvement of liver dysfunction and portal hypertension. In the patient with severe liver decompensation with hepatocellular carcinoma, treating Hep C in this particular patient did not impact on the wait list and also the mortality of the patient during waiting list. And SVR was pretty high. Moreover, if we treat the patient after liver transplantation, you can see on your right, up to a third of the patient may have significant liver fibrosis or fibrosing cholestatic hepatitis at the time of the treatment. And as a result, the treatment of Hep C, especially with long wait list, did not change in the HCC populations or recurrent after liver transplantation. So in this particular group of the patient, while we wait for liver transplantation, one should consider risk and benefit of the treatment. For the benefit of a treatment, you can improve liver function and may prevent the need for liver transplantation, and then you move the patient for local regional treatment. However, this improvement of liver function may prevent the patient from liver transplantation as well. So in summary, for the patient with hepatocellular carcinoma with active hepatitis C, for those who aim for curative treatment, we better treat the patient first and then treat hepatitis C after curative treatment. Duration after curative treatment to the treatment of hep C depends. You can treat right away, or you can treat wait for a few months before you initiate DAA, just to in case that the patient has early recurrence after curative treatment. In the patient with terminal stage liver cancer, survival is very short. In this particular group, there is no treatment for hepatitis C. However, in the patient with advanced stage SCC and require systemic therapy, some patients can have prolonged survival. In this particular group, we need to consider case-by-case basis. And use systemic therapy for the treatment of hep C did not affect on the reactivation of hepatitis C in this particular group. Sorafenib itself can affect on LAR pathway, which also block Hcv binding. Actually, early analysis for hep C related SCC, sorafenib has more benefit as compared with hepatitis B. With recent introduction of lenvatinib, another multi-kinase inhibitor, the result might be the same. And for the immune checkpoint inhibitor, using immune checkpoint usually result in no change of the viral load and abnormalities of the liver test in the patient with hepatitis C co-infection. The second subject going to cover on treatment in a patient with lymphoma. We all know that chronic immune stimulation can result in occurrence of lymphoma. For hepatitis C, with sustained B cell activation together with hep C-induced mutagenesis, all of these together for a long period of time can have genetic alteration and turn B cell into malignant B cell. For low-grade lymphoma, the treatment of hep C can result in partial or complete remission up to 72% in the patient with indolent lymphoma. So in this particular patients with active hepatitis C, usually we prefer to start treatment and then see whether how the lymphoma goes. Moreover, even in the patient with diffuse large B-cell lymphoma, combination after the treatment with chemotherapy and then initiations of DAA, the treatment can prolong disease-free survival and overall survival in the patient who have hepatitis C positive. Lastly, treatment of hep C in other active malignancy. And this is observational prospective study from the US to look at patients with active hepatitis C in many types of malignancies that include hepatocellular carcinoma and also many malignancies. So there were about 23% reactivation as defined by the increase of the viral load or in liver enzyme. However, most of reactivation were mild and asymptomatic. On your right, this is a typical severe exacerbations after the treatment with chemotherapy. In this case, cytarabine, idarubicin in combination with hydrosteroid. So the same study has found that the potential predictors for hep C reactivation include high dose of corticosteroid, use of rituximab, and baseline Hcv viral load greater than 6 log IU per mil. And as I said before, that reactivation occur up to 23%, but mostly unremarkable clinical cause. And presence of hep C is not contraindication for chemotherapy. So in summary, for the patient with solid malignancy, including hematologic malignancy, if they were infected with hepatitis C, so if you can start short-term cancer treatment and monitor whether there is viral reactivation or flare. And then if there is no viral reactivation or flare, and then the cancer is controlled or stable or in remission at least 3 to 6 months, then the treatment for hepatitis C should be indicated. In the long-term treatment of cancer, we can monitor for viral reactivation. For those with stable, even no cure for cancer, but stable or in remission, you can consider initiation of the Hep C treatment. But in the clinical trial or in end-stage cancer, especially when the survival is very short, less than 6 to 12 months, there is no need or no benefit for the treatment of liver cancer. In conclusion, ladies and gentlemen, treatment of Hep C in patients with active malignancy. For Hep C with hepatocellular carcinoma, in the patient with curative aim, the treatment can be delayed until after hepatocellular carcinoma treatment. And then the treatment of Hep C can initiate immediately or wait for a few months after the cure of HCC. It's going to be case-by-case basis for systemic treatment with active hepatitis C. Maybe the treatment can be considered in the patient with better survival. For indolent lymphoma, active Hep C treatment should be considered treatment. Other non-HCC malignancy, the risk of reactivation is low and mostly not severe. The risk and benefit assessment and consider Hep C treatment in a patient who have long survival. However, all treatment should be considered in terms of drug-drug interaction. Thank you for your attention. And with that, please join us at the Apostle 2021. The registration is still open. We are welcoming you to the Apostle 2021. Thank you.
Thank you very much, Dr. Tabasak. It was a pleasure listening to you. So with this, we come to the last topic of our symposium number 8. And believe you me, we've kept the best for the last. And with the topic of the last presentation is impact of DAAs on liver-related outcomes, all-cause mortality and HCC incidence by Professor Fasiha Kanwal from USA. She's the professor and section chief of medicine gastroenterology at the Baylor College of Medicine, serving as the investigator for clinical epidemiology and comparative effectiveness program from the Center of Innovations in Quality, Effectiveness and Safety in collaboration with Michael E. DeBakey VA Medical Center. Dr. Kanwal has authored and co-authored many articles that have been published in several peer-reviewed journals, including Annals of Internal Medicine, Hepatology, American Journal of Gastroenterology. She's a member of the American College of Gastroenterology and the American Association for the Study of Liver Diseases. We would like to welcome Dr. Fasiha Kanwal to take the screen, please.
Thank you very much for inviting me to speak on Fasiha Kanwal. I will be discussing with you the impact of direct-acting antiviral agents on liver-related outcomes, all-cause mortality, and HCC incidence. Before I start, let me just step back a little bit and discuss why are we talking about hepatitis C virus infection. It is because HCV is one of the most important causes of cirrhosis, liver cancer, and cirrhosis-related mortality worldwide. It is the leading cause of liver disease and liver disease-related burden in the US. Decade, and with the aging of hepatitis C infected individuals in the US, there have been a progressive increase in the number of patients with HCV-related cirrhosis and HCC. Here are some data from our group that first reported on this. These are data from the US Veterans Affairs or VA cohort of patients with HCV. If you look at the very far left at the blue line, looking at 1996, this point here represents the number of patients with HCV who visited any of the 130 VA hospitals in 1996 and had a diagnosis of cirrhosis at that time. Now, track that line over time, this proportion increased. Looking at 2006, it increased to 18 to 20%. So all the patients with a hepatitis C virus infection who were seen in the healthcare system in 2006, 1 in 5 had already progressed to cirrhosis, and 1% had a diagnosis of HCC by that time. Now, these are earlier trends, but these trends, they continued. We had access to the new DAAs. Now, with the availability of these treatments, the sustained virological response or cure rate increased to over 90% for most patient groups with HCV. And these treatments are going to change the natural course of HCV. For example, many studies have shown preventive benefits of achieving a virological cure or SVR. For example, in this paper of 503 patients with and without SVR, SVR here is in blue bar, without SVR, in orange bar. Now, these patients followed for a median of 8 years. Those who had SVR, the blue bar, had remarkably lower risk across all endpoints. Giving an example of HCC, the 10-year cumulative risk of HCC was 5% in patients with SVR compared to over 20% in patients who failed to achieve cure. But these data were from before the DAAs, and they do not directly address the outcomes of patients treated and cured with the direct-acting antiviral agents. In the next few minutes, I'm going to share with you some selected key data about this particular aspect. Here, to start us off, we conducted one of the first large-scale studies that looked at the risk of HCC in patients treated and cured with the new DAAs. We followed over 23,000 patients, excluded 79 who had HCC during DAA treatments. We had over 22,000 patients who completed the DAAs and had no prior evidence of HCC at that time. Among these patients, most, over 85%, achieved SVR. And then we followed patients who achieved SVR and those who did not, to look at the number of patients who developed liver cancer during the first 15 months of follow-up. Among patients treated with the DAAs, SVR, shown in the blue line, was associated with the considerable reduction in the risk of HCC. This decrease in risk started after around the first 6 months, but became more evident over time as months ensued. Variable analysis that adjusted for differences in patient characteristics, DAA resulted in almost 70% reduction in HCC risk in our study. Because most patients in our clinical practice over the next years to come will likely be those who are in sustained virological response, we also examined the factors associated with HCC in patients with SVR. So this is a table that shows those factors. Cirrhosis was associated with a higher risk of HCC. That was the most important factor. The risk of HCC was 4.7-fold, so almost 5-fold higher in patients who had already progressed to cirrhosis at the time of DAA treatment compared to those without cirrhosis diagnosis. African Americans had a lower risk of HCC, whereas those who had continued to use alcohol had a higher risk. Now, because cirrhosis had such an important influence on HCC risk, we also separated patients based upon whether they had or they did not have cirrhosis, to see if there were any other factors that drive HCC risk. Here are the data stratified by cirrhosis diagnosis. The risk of HCC was high in all patients with cirrhosis, with an overall risk of 1.8% per year. Now, remember, the risk of HCC beyond which HCC surveillance is considered to be cost-effective by different guidelines is about 1.5% per year. So this overall number is higher than that 1.5% cutoff. All patients with cirrhosis, regardless of other factors, had a higher risk of HCC than this cutoff. The risk of HCC was low in all subgroups without cirrhosis, except for this subset of patients who did not have a cirrhosis diagnosis but had a high FIB4 value, which, as you know, is a non-invasive marker of advanced fibrosis. Again, showing that patients with advanced fibrosis and cirrhosis remain at risk of HCC. In this study, we did not find any evidence that DAAs promote HCC during or after treatment. Now, many other studies have since then examined HCC risk in patients with a cure, and they found consistent results. With some data from some of these studies, the risk remains high, although the exact magnitude varies based upon the stage of cirrhosis, the risk being higher in patients with type B or C cirrhosis. However, in all these studies, the annual risk is above that threshold of 1.5% we just talked about, beyond which HCC surveillance may be cost-effective. So let me summarize the information that we just went over. Among patients treated with DAA, SVR resulted in marked reduction in the risk of HCC. However, the absolute risk of HCC remains high in several patient groups who achieved SVR, including that 40% of patients who had already progressed to cirrhosis. The annual risk of HCC ranges from about 1.5% to 7.8% in patients with cirrhosis. And this is important information because patients who already have cirrhosis, they need to be in HCC surveillance programs even after virological cure. Now, because DAAs are still relatively new, all these data that I just showed you were limited by relatively short follow-up of patients after DAA treatment. Most of the studies were looking at the HCC risk within the first 15 to 20 months following treatment. So what will happen as time from treatment progresses? Previous studies have indicated that fibrosis may regress in some patients. So there is a possibility that HCC risk may also fall over time with this. Well, it does not look like it. The first 3 years of observation following treatment. So here are more recent data from the same HCV cohort, now with follow-up through end of 2018, which gave 3.5 years of follow-up for patients who were treated with the DAAs. For this study, we calculated the quarterly HCC incidence rate as shown here in this graph. Now looking at the red line, which is looking at patients with cirrhosis, it shows the number of new HCC cases that develop during a given quarter. And if you follow this line, it remains fairly flat, showing that patients who were successfully treated with DAAs, but who were at a high risk of HCC given the fact that they had cirrhosis, this risk did not progress after up until 3 to 4 years of follow-up. It also remained above that threshold, the cutoff of 1.5%, beyond which HCC surveillance is cost-effective in patients with cirrhosis. These data have important implications for HCC surveillance, which needs to be continued in patients who are cured of HCV if they have cirrhosis. Now, the benefits of DAAs are not limited to reducing the risk of HCC. There are studies and data that show that these benefits extend to other outcomes that patients and we as the clinicians care about. Here is a study from 32 centers in France that followed a prospective cohort of over 10,000 patients with HCV. During a median follow-up of over 30 months, over 7,000 patients were started on DAAs, and there were 2,550, over 2,550 patients who remained untreated. There were differences in patients who did or did not get treatment, but after adjusting for a range of demographic, clinical, and liver disease severity related differences between treated groups, exposure to DAAs was associated with a 50% decrease in all-cause mortality. So it cut the risk of death by about half, and a more than 40% decrease in HCC, reconfirming and reaffirming the data I just showed you. There was no difference in the risk of progression to decompensated cirrhosis. Now, this could be related to a small number of patients who progressed to decompensated cirrhosis, but overall, across mortality and HCC outcomes, there was a marked protective effect. The decompensated cirrhosis numbers are different, but there are other studies that do show the beneficial effects of DAAs in patients who have advanced liver disease. I'm going to just share with you studies. So this is a prospective study of patients with decompensated cirrhosis who received DAAs through the English Expanded Access Program. The endpoints that they looked at were death, liver transplantation, liver cancer, and immune decompensation events between the start of therapy to 15 months post-treatment. So again, limited by relatively short follow-up. But the investigators also included an untreated retrospective cohort of patients over 6 months period for comparison purposes. So here, the first set of bars are for the untreated patients. The second set of bars are for all treated patients. And the last set of bars are those who achieved SVR. Compared to the untreated patients, there was a reduction in the incidence of new decompensation, both in the short term and in the intermediate term. So again, suggesting that the benefits do extend to preventing new decompensation in patients with advanced liver disease and prolonged improvement in liver function. I'm going to summarize the information that we've reviewed over the last 13-14 minutes in this last slide. DAAs have changed the clinical course and trajectory of liver disease in patients with hepatitis C virus infection. The annual risk of HCC is much lower after DAA treatment. However, it remains a high, or reduced, but still high enough in patients who have cirrhosis of the liver by the time they receive their treatment. This risk is from 1.5 to 7.8%, higher than the cutoff for surveillance, and also does not seem like that it falls off, at least over the first 3 to 4 years post-SVR. Important information, because these patients need to be seen in clinics for liver cancer surveillance. Treatment is beneficial in patients with decompensated cirrhosis, and it leads to prolonged improvement in liver function. So the benefits of treatment, they cut across the whole spectrum of liver disease in patients with HCV. Data also show that DAAs are associated with reduced risk of mortality in patients with HCV. So again, demonstrating the beneficial effect not across the spectrum of the disease, but also across the spectrum of the outcomes. So given these data, DAA treatment needs to be considered in all patients with HCV. Thank you very much for your attention.
Thank you very much, Dr. Fasiha. It was an amazing presentation, and thank you for endorsing the fact that we, being a resource-limited country, and we were treating decompensated cirrhotics, and we did notice an improved outcome, decreased hospital admissions, and decreased incidence of hepatic encephalopathy, and as well as upper GI bleed in our patients. So thank you for endorsing the fact. And now we can treat and manage those patients with more confidence. So we have made good time, and now it's the time for a little discussion. There's a question from the attendants, and this question is is asked by Dr. Asif, and he wants to ask Professor Dr. Saeed directly that how DAAs cause HBV reactivation and why this was not seen in interferon era.
So, difficult question. I think the answers are not very clear, but whatever it is there. So, the HBV reactivation is always dependent on a sudden rise in HBV DNA levels, right? Usually, not always, but usually dependent on a sudden rise in HBV DNA levels. How can that happen? It can happen by dampening down the immune system, for example, with steroids or with other immunosuppressive drugs, or it can happen in case of hepatitis C, supposedly by shutting off the activated interferons, interferon 1 and interferon 3, which hold the HBV DNA in check within the cells. So as soon as there is a dramatic reduction in Hcv RNA levels, the Hbv DNA levels go up because the interferons are released from their brakes. So that is the supposition. That is how this is supposed to happen. I hope that makes sense.
So that means that it has got something to do with the already ongoing inflammation in the liver?
Well, not inflammation. The inflammation is sort of more linked to the development of HCC, and Fasiha can address that if she wants to. The reactivation is mostly dependent on the interferons within the cell and immune systems outside the cell.
Dr. Fasiha, if you can hear us and if you would like to shed some light on it.
Yes, I'm here. Can you hear me?
Yes, we can. Yeah.
Can you repeat the question? Some difficulty hearing
And the
you.
question was that how DAAs cause HBV reactivation and why this was not seen in interferon era in patients of hepatitis B and C co-infection.
The exact mechanism of action, as Dr. Saeed mentioned, is not completely known, but what he described is what's the current understanding. So I really don't have a whole lot more to add to what he described.
Oh, that made it pretty self-explanatory. Coming back, I was more interested in patients that we were talking about who were decompensated. So, would it be beneficial? Though the data suggests that they improve the outcome, but what about those patients who are unable to undergo a transplant or are not accessible to a transplant unit, or whatever the reason be, they're not transplant eligible?
So the question is patients who have decompensated cirrhosis but do not have access to liver transplantation. I think the treatment actually makes far more sense for those individuals because they really don't have any other treatment options. The question about delaying treatment versus going forward with treatment is more relevant when patients are on the waiting list for liver transplantation, because then the MEL can change, and based on patients where patients are, what are the MEL scores, when patients are getting transplanted, those elements need to be considered in the decision-making process. But when there are really no other options for those patients, the only realistic option is DAA treatment. And as Dr. Reddy also presented in his presentation, it's not a guarantee that every single patient who has decompensated cirrhosis who receives DAA will have improvement. We've seen that it happens in half of the patients. There are some patients where the disease continues to progress even after DAA, but that half is still much more than zero or close to zero. So I think it's the benefit overall, on average, they outweigh any potential risks associated with DA treatment. And in a resource-limited situation setting where liver transplantation is not a realistic option, I think all the more reason to consider treatment for these individuals.
Can I request all my chairs and speakers if they can turn on their cameras? It would be a more fruitful discussion that way. It would be better to interact. Yeah. So from what I understand,
Okay, perfect.
From what I understand, oh, good to see you, Dr. Fasiha. From what I understand is that it's better to do something rather than doing nothing.
Absolutely. I'm hoping you can hear me okay.
Yeah.
I think I can. I'm not so sure if you can.
Yes, we can hear you loud and clear.
Yes, no, absolutely. That's exactly what the point is, that in a country like Pakistan, where liver transplantation is not an option for many patients, with the DAA, we actually have a realistic way to see that the patients do, giving them a chance of seeing some improvement in the liver function. Again, what I mentioned was it's not a guarantee, it doesn't happen in 100% of patients. But even if we can improve their MEL scores, improve their mean survival, even in half of the patients, this is more than what we could have done before.
Dr. Rajendar, if we can direct the same question to you, that do you do you treat advanced patients of advanced cirrhosis who are decompensated with with these DAAs? What would you do?
So thanks very much. I just want to comment on Dr. Conwell's I guess, presentation and comments. In essence, I do agree with what you stated, and we are both on the same page. I guess the point we need to make is not all decompensated cirrhosis states are the same. It's something we need to keep in mind. And also, we need to realize who amongst the decompensated cirrhosis patients respond. They're always the low-hanging fruit, like child class B6. Technically, it's decompensated cirrhosis. And yeah, they're likely to go into child class A. But you will look at child class C, particularly with the ascites, I think we need to have a good understanding of what the expectation should be from a physician perspective, or patient perspective, as you probably want to say, sab theek ho jayega. No, it's not like that. It's not everything is going to get well. But on the other hand, you can't deny a treatment. So Fasiha's presentation was great. Yes, there are lower rates of transplant, but that does not equate to complete improvement in quality of life. The low rates of transplant because we are inducing the state of MEL purgatory. So they're starting with a MEL of 20, 25, say you treat them, they go around to 14, 12, hang around there. And you can't get a transplant. So yes, numerically it'll look like the transplant rate is lower. But most studies don't look at improvement in CPT scores or MEL scores like we did. So I think it's a discussion that you got to have with the patient and say, well, there are certain expectations based on the severity of diseases where you might end up. And I would agree that there are fewer complications involved after therapy, but they're still, as I pointed out, hanging around there with an intermediate MEL. So what do I do? We are in a different situation in the U.S. apart from availability of transplantation. Unfortunately, there is an opioid epidemic, and there is availability of hepatitis C infected organs. So we MEL less than 15, for sure, we treat them. These are patients who are transplant candidates. 15 to 25, it's a case-by-case discussion. About 25, we target them for hepatitis C infected organs. So that's a strategy we do have in our center.
So what we can summarize it is that we cannot predict that who is going to benefit with it, but we will treat it that way. If you agree?
That's definitely correct. So, and we can predict it to some extent. The low-hanging fruit child class B6, MEL less than 15 without ascites, the European shown that they are more likely to be delisted. So MEL less than 15 with ascites may not do well. So it kind of need to have certain expectations.
Well, I can
I
see
would add to,
yes, Dr. Fasiha,
as
please.
Dr. Reddy mentioned, that is very pertinent for a scenario, a healthcare setting where liver transplantation is a realistic option. And those discussions are only relevant to those settings, which is fortunately the way we practice. But there are many settings in the US and outside of the US where liver transplantation is not really a realistic option. So I think that that's the point that I was also making, that if liver transplantation is an option for a patient, then these discussions become more nuanced, and also exactly not the same rules will apply to even the same region, because the MEL scores by which patients get transplanted vary across regions. So it has to be more patient-tailored, region-tailored discussion and conversation. But where liver transplantation is not an option, such as many places in Pakistan, treatment is really the only realistic option for seeing any improvement in patients' chances of overall survival. So I think that's, you have to weigh what the resources, the risks, and the benefits, and make a decision. But before DAAs, we didn't even have, these conversations were not even happening. So I do think and believe that DAAs have changed our ability to make a difference in patients' life, and overall our ability to bend the this rising curve of hepatitis C-related morbidity and mortality that we were experiencing. So that's sort of how I see things.
So what we are going to take home from here.
Just one quick point to support what I've said in terms of the degree of improvement, and Fasiha should know the paper. She's the editor-in-chief of a paper of the journal where we published a paper. We looked at delisting rates for liver transplant. In the DAA era, delisting from the liver transplant list for improvement is about 6%, and it's been the same almost compared to the pre-DAA era. So fair number of patients are improving, but not enough to come off of the list. So that's another point about the degree of improvement I want to make you all aware of.
So what we're taking home from here is that treat as many as we can when we can. So I can see Dr. Tanwandee on screen, and we would like him to shed the light on what is his practice in his area, and what does he do if such of a patient as HCC, an early HCC or a developing HCC, what would you do, Dr. Tabasak? Professor Saeed, you can join us.
The chat from Professor Gibbs regarding the reason to treat all HCC patients immediately. But so far, if you are looking for curative treatment, it doesn't take so long. It's going to be like a surgeries or RFA. It just takes a few days. So then after that, you can start the treatment after curative treatment. That can be immediately after curative treatment, or you can wait. It depends, because in case that you have your gut feel that they're going to be high risk of recurrent, then it's going to be quite problematic when you are in the middle of the treatment, and then you got to start treat recurrent HCC for the second time. But in case that you feel that this could be fully curative, then you can start treatment right away.
Professor Saeed, you wanted to add something?
Just perhaps the last question to both to Fasiha and to Dr. Tanwandee. So I think it is now pretty much settled that the DAA therapy does not increase the incidence of HCC in these patients. I hope you agree with me. But what is not clear to me, at least in our clinical practice, is do DAAs, the post-DAA treatment therapies, we see very aggressive tumors. Is that somehow related to DAA therapy or not? What is your reading of the literature?
So far, I don't think that's going to be the issues because most of the studies so far have included small study, either small and retrospective study. So, but it may be, Professor Said, what you mean by aggressive tumor? Is that with a small tumor or at the times of large tumor?
I'm talking about large tumors which are involving veins and portal veins and so on and so forth, and are largely incurable.
And that occurs during the treatment or before the treatment?
This is usually what we're seeing is after therapy. So I don't know.
But when you look at the data, and now there are quite a few studies that have looked at it. The one that comes to mind, the larger one, is from the US. I want to say were 20 different centers. It was a retrospective study, so that's the limitation. That followed a large group of people. I want to say maybe close to 800 patients with HCC that were treated. The HCC was thought to be under control. Or there DAAs after that. And after careful analyses, there was no difference in the rate of recurrence of patients who received DAAs versus who did. And they looked at it multiple different ways, but just that those results did not change. Also, HCC-related mortality was no different. If anything, actually, patients who received the DAAs had some reduction in mortality after DAAs. So those case series, those case reports are out there, but when you step back and look at the larger collection of data.
Thank you very much. It's HCV and HCC is such an enigma that we would like this discussion to go on, but the time is flying by and we are time restricted. Let's have a quick comment from Professor Zagham Abbas. He's with us and he wants to share his thoughts. And if you can summarize the symposium with this.
Okay, I just wanted to know if Raj is still there. Because in Pakistan we are facing problem that most of our patients that we see who are the non-responders are the cirrhotic patients, like this has been mentioned, with low albumin and advanced fibrosis. This is only comment that what I have seen is that we are using SOF with velpatasvir, but we do not care about the degree of fibrosis. We do not do the simple calculation of FIF4 or APRI. That are very much helpful to whether to add ribavirin or not.
So we conclude this session with us, as we have to move on to the next, the symposium number 9, and it's going to be an even interesting more topic, which is going to be related to hepatitis B and D. So with this, I would like to thank our chairs, and our panel of experts, and I would like Professor Saeed Hamid to please conclude the session.
Well, thank you very much, everyone, for taking the trouble. I know you're in various time zones. Somebody is at night and somebody is early morning. But you all look so fresh that it is wonderful seeing all of you on the screen. Thank you very much and have a nice weekend. And many thanks for being part of this symposium. Thank you.